Hello, YouTube. Welcome back to my channel. My name is Dr. Daniel Kaplan, and my mission is to make psychology accessible to all. In today's video, we're going to talk a little bit about the ways we conduct an assessment. Our previous discussion was on the process of assessment leading to a diagnosis and diagnosis leading to treatment. But now we're going to talk a little bit about the various processes. Now, when doing an assessment with children, we operate using a multi-method approach. So there might be some kind of clinical interview coupled with some kind of psychological test, some survey rating scales, and so forth. But I'm going to go into each of the various ways we tap into and collect data that inform our assessment and diagnosis. So let's get into it. As I just mentioned, when conducting a psychological assessment, we typically use a multidisciplinary team approach, and that involves collecting or obtaining information from different informants in a variety of settings. So we will collect information from the child themselves, the parents or guardians, teachers, and any other relevant individual, such as pediatricians sometimes, especially in the case of eating-related conditions. So we'll collect information, but how do we collect this information? Well, one of the more common approaches are interviews, observations, questionnaires, and tests. Let's get into each one. A clinical interview. Clinical interviews are wonderful because it allows you to get a large amount of information in a very short period of time. It could include the developmental or family history, and usually in a psychological report, there is the background information, which includes this developmental and family history. Now, there are different kinds of interview styles. There's the unstructured, semi-structured, and fully structured style. An unstructured clinical interview is basically more conversational, and you're asking questions. As the person is responding, you go wherever they go. And one of the problems with an unstructured interview is that you may run the risk of not getting sufficient information by the end of it. You may miss certain areas of the child's life, major domains. And because there is limited structure to it and it's more conversational, we don't have as great reliability. What do I mean by reliability? If I do an unstructured clinical interview and one of my colleagues does an unstructured clinical interview, it's possible that we may go in very different directions, and that could lead to biased information. So most clinicians use what's called a semi-structured interview because they're a lot more reliable. Now, how does that work? A semi-structured interview has programmatically a series of prompts for each domain. So you have some specific questions you know you're going to ask everybody, and then you go from there. So, for example, if I were to ask a child, tell me about your home life, everybody might get that first question. And that's the semi-structured part. Those are the specific questions I might ask. And then from the description of the home life, I can move on to other questions that are tailored to the individual. But everybody's going to get a series of questions. If I want to go to the next area, I might go to a place like education. How are you doing at school? Are there your favorite or least favorite subjects. And there are certain questions I'm going to ask everybody, but then I go off from there and allow them to go in whatever direction they're going to take me. Now, that is the way that most of us do it. There is a fully structured interview. Most of us don't do that. If it's a fully structured interview, you're going to ask all of the same questions to everybody. And that can be a little bit robotic. It can also, while sure you're going to get the same information, those very important follow-up questions that a semi-structured interview allows you to do, you're going to lose that, because if it's fully structured, you're only asking the questions that are on your sheet, so to speak. So the most ideal, the way that I do it, and I'm sure most of my colleagues do it, is through semi-structured interviews. Now, when you do a semi-structured interview, you have to know who your informant is, right? So you might do a semi-structured interview with the child, but if the child is very young or may not be a good historian, you might include other informants, such as a parent, and you might ask a parent to give more information about the things like prenatal development. We don't expect the child to know any kind of developmental milestones at a very young age. A child may not know. So you're going to take this information from oftentimes the client themselves and their parent and or guardian. We could also do what's called a behavioral assessment. Now, when I move to the behavioral assessment, this may not be to the exclusion of the clinical interview, because as I said, we use a multi-method or multimodal approach. It's very important to understand that. So you get that clinical interview, but you could also do a behavioral assessment. And a behavioral assessment, what you're doing is you're watching the child as they're engaging in a task, and you're taking note of their thoughts, feelings, and behaviors, and you're going to do what's called a functional analysis of their behavior. So there are these specific target behaviors. We want to understand what drives whatever the behavior of concern is, and we do what's called the ABCs. ABCs stand for antecedents, behavior, consequences. An antecedent is what led up to the behavior. What was the trigger? What was the distressing thing that led to the action itself? The behavior is what the child said or did. And then the consequence, which is very influential in either increasing or decreasing the likelihood of a behavior. We pay attention to what was the consequence of the behavior. And through these three patterns, antecedent, behavior, consequence, we can have a good understanding of what the problem area is, or the primary problems of concern, and then we can develop what's called a behavioral plan to engage in some modification of the behavior. So, as I said, we're going to try and identify as many factors as possible that could be driving the child's behavior, thoughts, or feelings, right? A lot of this is the antecedent or the triggers, so to speak. And then we're going to formulate some kind of hypotheses as to which of these are most important or easily changed. Sometimes we go based on a priority system of risky versus non-risky behavior. So if you're working with a child on the autism spectrum, when you're developing a plan, you're going to target self-harm first, right? So if the child is self-abusing, banging their head against a wall, biting or scratching themselves, things like that, you're going to target that set of behaviors before another set of behaviors. So we have to think about, well, what is the most important? But if there are no risky behaviors involved, we might say, okay, how do we get some momentum? Let's target the behaviors that are easiest to change and go from there. Now, we gather information from the parent, the teacher, or the child, and we also gather information through observing the child. Now, I said we do a clinical interview as well. Why are we doing the clinical interview? Well, that's to get the background information. But one of the problems with clinical interviewing is that people lie. There is an honesty issue. And especially when working with parents, there is a natural tendency to report one's child's behavior in a more favorable light than is really true. And a teacher might report a child's behavior in a less favorable light than is true. So in addition to getting that background information, we do want to observe the child and see what they're doing, because that is in real time what is going on. One of the challenges with observation, though, is that when children know they're being watched, it could affect their behavior in of itself. So behavior changes when people feel they're being observed. And we get out of this, or we have a way of dealing with this by doing unobtrusive measures where we might sit in the back of the room and not call attention to ourselves and observe from afar, or we might allow the child time to get used to us so that their behavior can normalize and we could see what is typical of their behavior. So we've talked about the idea of clinical interview. We talked about behavioral strategies. And here is just another way of thinking of the ABCs. Let's say a child had a thought, and I'm going to pick one in particular. I'm no good at anything. Well, that's going to result in an increase of depressive symptoms. And as the depressive symptoms occur, it's going to reinforce or confirm their low self-esteem. Let's say a child has separation anxiety, and they're asked to go to school. They might report some kind of physical complaints, which leads to them staying home, and that might reinforce the separation anxiety. So here are just a couple of the antecedent behavior consequences. Now, a third approach are checklists and rating scales. Now, checklists and rating scales, these are validated instruments that are designed to focus on one or more aspects of a child's functioning. When we talk about checklists, checklists tend to measure multiple aspects of the child's development, so they tend to be more global, whereas rating scales tend to be more specific to an individual aspect of functioning. So rating scales are broader, more global, tap into more areas of functioning, whereas rating scales tend to be very specific. And similar to the clinical interview and the observations, these can be used to ask parent, teachers, and children themselves to rate themselves. And it could be a yes, no, whether the child experiences that behavior or symptom or not, so the presence or the absence, or it could be on a spectrum, on a Likert scale, which measures the relative frequency or intensity. So one of the more popular instruments we use is called the Child Behavior Checklist, or the CBCL, which is really great in working with school-age children and trying to understand behavioral concerns in children and early adolescence. So just to give you an idea of some things we might tap into, and because it's a checklist, we're tapping into a whole host of areas of functioning. So let's look at internalizing and externalizing behaviors. You have anxious, depressed, and somatic behaviors. Externalizing behaviors are rule-breaking behaviors or aggressive behaviors. And then there's some kind of neutral ones. If we were to look at this profile, we would be able to interpret that this child is struggling with anxiety and depression. And how do we know this from the CBCL? If you look at the clinical elevation, right? So it says clinical range. There are 2 dots that are in that clinical range, and they are anxiety and depression. Now, we do have other scales that are elevated, right? So somatic complaints is somewhat elevated, and we have social problems as somewhat elevated or on the border of elevation. These are still of concern, and they can create some further problems down the road. But if you were trying to understand the functioning of this child, the CBCL would say, hey, we need to work on anxiety and depression. And this is a checklist. Now, checklist, the child or parent or teacher is filling out a bunch of questions, and they're saying, yes, no, this is present or absent, or mild, moderate, severe, right? So there are ranges of impact of the behavior as well. So that's what you get out of a clinical rating scale. Now, we also can encourage behavior observation recordings, and we talked a little bit about this. Now, we might invite parents or other people to mark baseline data. So we would say, okay, well, what's going on with the child before treatment? How often are they being aggressive during playtime or recess? And we take note, and that serves as a pre-treatment measure. Then we might engage in treatment, which we'll talk about in another video. And then we're going to take that same observation and see if the behavior is increasing or decreasing as a function of the treatment. So that's called RTI, response to intervention, right? So we want to keep track. We knew before treatment they were acting this way. After treatment, they're behaving this way. Now, the recordings can be done by parents or other people. We can even have some kind of, it used to be a beeper that would buzz, and then you would write what the child is doing at that moment. And if there were problematic behaviors, they would record the intensity of the symptoms, and it would be kind of spontaneous. The parent would get it, or the child might get it if they're older and can do it for themselves, and they would write down, and we'd try and see if there was a pattern in behavior. One of the problems with these beepers or other, maybe it's now it would be a text message, okay, it's time for you to take a reading. It's hard to ensure accuracy, right? So who is to say that the parents or the child are reporting accurately what's going on and what they're actually doing? So there are other ways to do it. There are role play simulations we could see, and we could observe how a child interacts with others in a role play scenario and so forth. And some clinicians do that. And I know it's done heavily in research settings if we want to understand behavior. We also have psychological testing. Now, psychological testing, these are given under standardized conditions. That means that there is a manual that tells exactly how to administer the test. There's also at the back of the manual scoring guidelines, so everybody is scored the same way. So the tests are taken under standard conditions, whether it be a skill set, personality, intelligence, or whatever it might be. And then we compare an individual's performance relative to the larger group. Now, what's cool about using psychological testing in addition to things like a clinical interview is you're getting more of the nomothetic approach, the group norms, right? The clinical interview, you were getting the idiographic information, the unique experience of that child or their family. So, as I said, uh, psychological tests have been validated, so they tend to have norms based on specific samples. And one of the criticisms of some of our earlier tests is that they were not culturally fair for racial or ethnic groups or a non-US sample, et cetera. So when using psychological tests, you need to make sure that they have been validated for the racial, ethnic, or cultural group you're working with. And there's a guideline. There are ethics codes. So there's a code for fair testing practices, which requires us as clinicians to do our best to be sensitive to cultural factors that might impact the score. And it is not uncommon if you give a psychological test and you see something is amiss to write in your report that these results should be interpreted with caution. And you explain why. There might be these contextual forces that resulted in perhaps a less reliable or less accurate depiction of the child. We also have developmental testing, right? So developmental tests are used to screen or assess infants and young children. Generally, we want to see with screening whether or not there are children are at risk. So a good example might be at a pediatrician's office. There is a screening for autism at 18 months and 24 months. Those are the recommendations of the American Academy of Pediatrics because we're trying to do early detection of individuals on the autism spectrum. And then if there is some kind of flag for potential autism, then you refer for a more thorough evaluation. And then you do the evaluation, and it might lead to a diagnosis, and that diagnosis is very, very important because it drives the treatment that the child gets. And one of the things we see is early intervention is effective. So the earlier you start to address whatever the problematic behavior is, the better the prognosis, the better the likely outcome is going to be. And we've known this for a while, but there's stronger and stronger emphasis on doing early identification and treatment of mental health conditions. So as a function of that, laws have been passed and there are current public policies that require these screening. And I mentioned the American Academy of Pediatrics and autism spectrum because those are the guidelines that they put forth, which inform public policy. So let's talk about a form of cognitive testing. So there are what we call IQ testing. IQ testing is intelligence testing. That is one of the core measures of cognition or cognitive functioning. And then we have achievement testing, which is more about your academic performance. And if I were to ask you what is the definition of intelligence, you probably would struggle to give me an answer. And in fact, the experts in the field have different definitions of intelligence. So for clinicians, we tend to boil things down to whatever psychological test you're using. And an example of a psychological test which you would use is the WISC. And the WISC can be used from about 6 to 16 years old. So it's a wide range. And during the school age years, you can tap into intelligence functioning, whether it be fluid reasoning, so your spatial awareness, your mathematical ability, whether it be your abstraction or higher order thinking or processing speed, how quickly and accurately you do a task. These are built into the Wechsler test. We also have the achievement test Wechsler has, and these are related to reading and arithmetic and all of those academic domains. So we can tap into your aptitude through an IQ test and your achievement, how you're performing in the classroom. And a disability would be present if there are significantly low scores on both, for sure. But even if you have what's called a 1.5 standard deviation difference between IQ performance and achievement performance, you could talk about some form of a learning disorder or learning disability. So giving an IQ test and achievement test is important, and it allows us to detect pretty early whether there are some kind of learning difficulties or disorders. We also have projective tests. Now, projective testing are linked to personality oftentimes. So you might show a series of ink blots and ask a person to say, well, what do you see? You might show a scene on a card, like a children's apperception test, and you might ask them to tell a story that has a beginning, middle, end, of thought, and feeling. And the beauty of projective tests is that they're ambiguous and allow for us to tap into aspects of personality that you may not admit readily. So you might project your personality, fears, or conflicts onto the test. And there are some questions about projective testing. Those of us who use projective tests, we don't use them in isolation. We use them in conjunction with other tests as well. But one of the criticisms of projective testing is that they have weaker reliability oftentimes than standardized tests that we talked about earlier. So you have to be very careful and only use them as part of your assessment process. It could inform or reinforce other data points you already have established through a clinical interview, a series of screening instruments, and standardized testing. So this is just one component. Now, we also have to be mindful that a lot of these projective tests have to be established in terms of standards when using with individuals who are Black, Indigenous, or other people of color, because similar to the standardized tests, it doesn't always match the experience of underrepresented groups. Now, personality testing or larger objective personality testing, we have a whole host of instruments we can use. So if you're interested in just basic personality functioning, we could tap into what's called the Big Five. So that's openness, conscientiousness, extroversion, agreeableness, and neuroticism. So these are aspects of personality that we all have. And the Big Five has been established in all 6 inhabited continents and over several dozen countries, and it's pretty consistent in its outcome. So the Big Five can be used for quote unquote normal personality, but you could also use other inventories to detect some kind of, diagnostic issue. So the MMPI-A, the Minnesota Multiphasic Personality Inventory A, is for adolescents. So we could get a whole bunch of clinical scales through that MMPI. And a personality inventory for children is just another example of a personality assessment we could use to tap into domains or aspects of personality functioning. Now, one of the issues with the labels that come out of personality testing is that it could be stigmatizing. So we have to be very careful in how we write up our reports. And to the extent that we use the labels, we have to explain it more. Most of us try and describe what the label means rather than just using a label. So that would help reduce some of the stigma and stereotypes that are used for underrepresented groups. We also have neuropsychological testing. So here, this is more about brain functioning or higher order cognitive functioning. So neuropsychological assessments are a battery of tests that might tap into verbal and nonverbal cognitive function, spatial awareness, motor functioning, emotional regulation factors, other executive functioning. So there's the KABC. There are a lot of neuropsych tests that you could use. And that's where I want to stop for now in terms of the assessment. So to pull back more broadly and recap, what I wanted you to get out of this video is an understanding of the different strategies we as clinicians use to gather information, to do our assessment prior to coming up with a diagnosis if appropriate. And you see that it's a very complex and integrated system that includes interviewing, rating scales, standardized testing, sometimes projective testing, IQ and achievement testing, personality testing. Now, I said that we use a multimodal approach. We're using various methods to do the assessment. You wouldn't necessarily use all of the methods at the same time for every assessment with children. How do we know which approaches to use? The answer is simple: the referral question. And whatever the child was referred to you for to determine, that's going to guide what kind of instruments you use. So if I was trying to detect a learning disability, a lot of those personality inventories would not be used. I would use the IQ test, I would use an achievement test, I might use some adaptive functioning test if I thought something else was going on related to perhaps autism or whatnot, but I wouldn't use personality. Whereas if there were some behavioral problems and perhaps some psychological distress, I might use the personality inventories, or I might use the CBCL. So that is the quick lesson on psychological assessment. I hope you found it useful. If you did, hit the like button, subscribe, click the notifications tabs. These will allow you to know when I issue a new video, and you could track that progress with the notification tab. And the like button is very important for YouTube because it allows them to know there's value in this video. And as a function of that, they will push it out to a larger audience. The last thing I will say, as I say in all my videos, is if you have a thought or reaction to the video, if you have a question about the video, please put it in the comment section below. I read and respond to every comment I get, and it is part of making this video come alive a little bit more. So I look forward to your questions and comments. Until next time, take care, everybody.